Hi there, everyone. We're going to start right on the dot tonight because we have a lot of information to get through. So thank you so much for being with us. My name is Elizabeth Errico, and I am the Executive Director of the Children's Mental Health Resource Center. And for those of you who are new to CMHRC, I'd like to share with you a little bit about who we are before we get started. We are a national nonprofit organization that provides guidance and resources for the early identification and management of mood disorders, bipolar disorder, and fear of harm. We work with families who have children as young as 5 or as old as 35. And we work to make sure that families have the services that they need, but we also work to make sure that practitioners have the services they need too. These disorders are isolating for children and for families, and they are complicated for providers to treat. So we at CMHRC are here to break down that isolation and to provide the support that everyone needs to ensure that children get an accurate diagnosis and a treatment plan that works. You can learn more about our programs and services on our website at cmhrc.org. So I'm going to be a little bit louder. Someone looks like someone was saying it was hard to hear. So I'm going to try to speak up a bit. So tonight I have with me Jennifer Sevick, who is CMHRC's clinical coordinator. She is handling the Q&A panel. So please, as I'm speaking, feel free to add your questions and comments in there. She'll be able to answer questions for you as we go. And if there's time at the end, we'll have a Q&A where she'll be able to bring some of those questions out for us to answer at the end. If you have questions or concerns or comments, please feel free to email us at admin@cmhrc.org. Now we're going to get started. So we don't talk about biological markers or biomarkers in mental health very often, in part because it's extremely rare. Actually, until recently, there haven't been any that have been identified in association with a mental health disorder. But very recently, a newly identified phenotype of bipolar disorder, which researchers dubbed fear of harm, or FOH for short, until now, now we finally have a biomarker for a mental health disorder. But before we can really dig into it, I want to talk about what biomarkers are and why they matter. So what is a biomarker? The term biomarker actually gets used in medicine a lot. It means that there's some sort of flag or marker that can be measured and identified. And it indicates whether or not a disease is present, and if so, how intensely. Biomarkers can be found in the body and they can be measured. And an easy example of a biomarker is an antibody. And so we all learned during the COVID-19 pandemic that a blood test could show whether or not antibodies were present in the blood. If they were, then we knew that that person either was in the process of fighting off the illness or had recently recovered from fighting off the illness. And those antibodies were a biomarker for the presence of COVID-19. Biomarkers are useful in a lot of ways. They can tell us if a disease is present or not. They can tell us how far along an illness has progressed. They can give doctors clues as to how best to treat the illness. Or they can figure out someone's risk of developing a disease. Biomarkers are actually a really important part of medicine, and they help with early diagnosis, disease prevention, and medication identification. In short, a biomarker can tell you if an illness or disease exists in a specific person at a specific time. So it's actually pretty special that this newly identified phenotype of bipolar disorder, which we call FOH, has an identified biomarker because it changes how FOH gets diagnosed and treated. In our webinar in February called Understanding Misdiagnosis and Childhood Bipolar Disorder, we talked about the fact that kids get misdiagnosed a lot. And they're often misdiagnosed with disorders like ADHD, oppositional defiant disorder, disruptive mood dysregulation disorder. And this is not only happening because FOH hasn't made it into the DSM yet, it's also happening in part because of how the DSM is structured and used. So now, for parents in the audience, you may be wondering why you need to know anything at all about the DSM or its history. But in order to get your children the help that they need, it's important to know how and why your child's care providers are using the strategies that they're using to diagnose. So equipped with this information, you become not only a parent, but an informed advocate for your child. So we're going to take a little bit of a detour and talk about how practitioners use the DSM, which will help us understand how and why having a biological marker changes that process so dramatically. So the Diagnostic and Statistical Manual of Mental Disorders, otherwise known as the DSM, is the authoritative text on diagnoses, and it sits on the desk or shelf of every counselor, therapist, psychologist, psychiatrist, social worker, everyone in the field of mental health, at least since 1980, has been taught it, has been trained to use it, and uses it really almost every day. The DSM is currently on its 5th edition, which was published in 2014. The 3rd edition was published in 1980, and it was the result of really a complete redesign and rethink. You see, the field realized that it needed to increase the likelihood that psychiatrists in different places at different times would see the same patient or the same set of symptoms in different patients and provide the same diagnosis, which prior to 1980 wasn't always happening. So in order to make that possible, the writers of the DSM made a specific and conscious choice about how to diagnose. And they decided to focus on identifying specific observable symptoms of each disorder and organize them into lists of diagnostic criteria. Most importantly, they decided that this diagnostic process would be neutral with respect to causes. That meant there was a basic agreement in the field that there were no causes of the disorders that were listed in the DSM, or at least we weren't going to speculate on what those theoretical causes might be or consider them while diagnosing. Now, some of you might be thinking to yourselves that can't possibly be true, but I assure you it is. And the publishers of the DSM, which is the American Psychiatric Association, they don't hide this. In fact, they state it clearly and intentionally. And this quote is directly from the APA, that the DSM was developed using an approach that attempted to be neutral with respect to causes of mental disorders. But everything that we know from the field of medicine tells us that without knowing what the cause of a disorder is, it's much harder to find treatments that will do more than, put bandages over symptoms. So in other words, without a cause, there's no real chance of actually stopping it. So currently, Treatment for mental health issues is about addressing symptoms, not causes. Just like with the common cold, where we treat symptoms like a runny nose or a cough or nasal congestion, since we can't look for a cause in mental health, we can't treat the cause. So this focus on symptoms actually leads us to a problem that we talk about over and over again, actually. And it's what happens when two different disorders have the same symptoms, which actually happens so frequently that the DSM authors address it in the introduction to the book. And they talk about the fact that, and this is a quote, mental disorders do not always completely fit within the boundaries of a single disorder. Translation is that symptoms overlap. And that can lead to misdiagnosis. But it also leads to another problem that most people haven't thought about, which is what happens when two patients have different symptoms but are given the same diagnosis. And it might seem like this can't happen, but it actually does happen more often than you might think, because in this whole process, we've ignored cause. So you may be asking yourself at this point, what does all of this have to do with biomarkers? Well, the answer is that this shows us a flaw in the system that ignores the causes of mental illness. But biomarkers change that because they are biological symptoms. And in the diagnosis that we call FOH, researchers have identified a biological marker, and it's the first ever for a mental health condition. And this biomarker, this physical symptom, can be objectively observed and objectively measured. And it indicates the presence of an illness, and it can assist in the process of diagnosis, and it changes how treatment is delivered. Because FOH has a biomarker, it's a disorder that has a cause. And this means we know what the biological cause is of the symptom, and we're seeing that we can treat the underlying cause of the symptoms instead of coming at it solely from a standpoint of treating, quote, behaviors. So what is this biological marker in fear of harm? It's that the brain can't properly control and regulate body temperature. And this thermoregulatory dysfunction underlies and triggers a cascade of other symptoms that up until now have been viewed as solely psychiatric or behavioral. So the best part of having a biomarker is that it isn't dependent upon the patient, regardless of age, 5 or 45. It doesn't rely on them having to report their symptoms, or honestly, even really truly be aware of them at all, because the biomarker is totally independent and can be tested for. So in FOH, we can test for this biomarker, and when it appears, we know that this cluster of behaviors or behavioral symptoms are actually being caused by temperature dysregulation, and that the diagnosis of FOH is correct. It gives us a cause of the symptoms. It provides a path to treatment based on cause, and it addresses that cause instead of, as I said before, just slapping a bandage on the symptoms. So now we're going to take a closer look at this biological marker for the FOH diagnosis, which is temperature dysregulation. Generally speaking, we define temperature dysregulation as the brain's inability to correctly control and regulate the body's temperature. It can't keep it stable. This is observed in the disruption of normal difference between the inside body temperature and the outside body temperature, or the core temperature versus the shell temperature. In scientific terms, we call this proximal versus distal temperature. Obviously, these two temperatures aren't the same on anyone. The tip of our nose isn't going to be the same temperature as our stomach. But there's a normal, established, known differential between these two temperatures. And when it's out of whack, that tells us that the body isn't releasing the heat that it generates properly. And this inability to release built up heat, this inability to regulate body temperature in FOH patients, results in all sorts of different symptoms that have been viewed as psychiatric or behavioral. But for now, I'm still going to focus a little bit longer on explaining what this temperature dysregulation looks like, because once you know what to look for, it isn't actually that hard to spot. In fact, most of the signs of it are like right in front of a person's face. They just don't notice them or connect them to mental health or mental illness because they've never been taught to associate the two before. So there are specific scientific methods that researchers use, and the researchers who first identified FOH and continue to study it, that they use to document temperature dysregulation. And this includes taking temperatures on multiple parts of the body at multiple different times of day, using a special thermometer over the course of several weeks to months, and graphing it, and et cetera, et cetera. This brings scientific validity to the diagnostic process, but frankly, this is totally unnecessary most of the time because the indicators of temperature dysregulation are abundantly clear once you know what to look for. So for diagnosing a thermoregulatory problem in kids or teens or adults, we can simply look for the presence of two or more of the following criteria. They feel excessively warm or hot at bedtime and overheat during the night. They feel cold in the morning after having felt hot at bedtime. They feel excessively warm during the day in neutral temperatures. They show moderate to extreme tolerance to the cold. And they overheat or sweat profusely with minimal exertion. Or temperature dysregulation. Oops, I'm on the wrong slide. Apologies. Temperature dysregulation is most often described by parents in shorthand as just overheating. And while it's more complex than that on a scientific level, it is a useful shorthand descriptor because these overheating symptoms occur during the day as well as during the night and during sleep. So we're going to look at these three different cases. The physical signs of overheating include sweating a lot during regular exercise. Now, during exercise, you're supposed to sweat, but there's a difference between an expected amount of sweat and really sweating excessively or profusely. There's also sweating when it's not particularly hot out. You're in what appears to be a neutral ambient temperature, and nobody else is overheating or sweating, but the person with this temperature dysregulation issue is. The next sign is a flushed face, warmer than usual skin. Sometimes parents describe children who have this dysregulation as being like a little radiator, and they can put their hands next to the child's face, forehead, back, or chest, and feel heat radiating off them. Also, a telltale sign of thermodysregulation is bright red ears that are actually red, warm, and can be actually hot to the touch. In addition to these signs of overheating, during the day, parents and family members of people who have this temperature dysregulation issue also notice that the individual has a tolerance to the cold and is comfortable outdoors in icy temperatures without wearing weather appropriate clothes. In fact, many parents report that they have arguments with their kids because the children won't agree to wear weather appropriate clothes like coats, jackets, sweaters, sweatshirts, or even long sleeves or long pants most of the time, including in the dead of winter. Kids with temperature dysregulation issues want to wear summer clothes all year long, like shorts and t-shirts and sandals outside in freezing temperatures. Many parents report that trying to get their child to put a coat on in the winter to wait outside for the bus can turn into a knockdown, drag-out fight. But when you understand temperature dysregulation, we can understand why they're doing this. Wearing a coat makes them feel hot, and their body can't cool them down effectively. So they never acclimate to wearing the coat in the way those of us who can thermoregulate do. And this dysfunction winds up leading to other symptoms. Sometimes the person with temperature dysregulation will refuse to wear really clothes at all most of the time when it's socially appropriate. Often kids will strip off their clothes the second they get home, or when they get into the car after school in the afternoon, and they'll spend most of the time that they're at home sitting around in just their underwear. They may refuse to put on any clothes, socks, or shoes until the last possible second before leaving the house. Parents and other family members often see this as difficult or oppositional behavior because the person isn't completing the task that's been asked of them, which seems on the surface to be very simple. Just get dressed. But this dislike of clothing makes sense when you consider that thermodysregulation causes the body and the skin not to release built up heat properly. So when you start off with that problem and then you add layers of clothing that trap that heat next to the skin, you can see why that might be intolerable. And now that you understand why wearing clothes feels so terrible, it is, I think, pretty easy to realize that they're not putting it on intentionally to be oppositional or defiant. Another aspect of the cold tolerance is difficulty actually sensing what temperature it is outside, because these folks literally don't feel cold. This has its own negative consequences because even though they don't feel cold, their body is registering that it's cold outside, and the body then starts to generate heat to keep itself warm. And the problem is that once the body turns on that furnace, it likely won't recognize when they go back inside that it's time to turn off the furnace, which means that it's just chugging along, running, creating heat all of the time, making the person warmer and warmer throughout the day until all of that undissipated heat becomes overwhelming in the late afternoon and early evening. This leads to issues of overheating that last into nighttime, which starts with feeling excessively warm or hot at bedtime, leads to overheating during sleep, and culminates with feeling cold in the early morning. At bedtime, they may feel so hot that they can't get into bed, get comfortable, or settle down. And sometimes they won't even put on their pajamas. In both of these cases, parents are inclined to see this behavior as oppositional or uncooperative or avoidant, when in fact, it's really just the result of built up heat. During the night, overheating usually results in kicking off the bed sheets and blankets and sweating while asleep, sometimes so significantly that the bed sheets are damp or wet from the sweat. And the early morning cold, those feelings are also part of the faulty temperature regulation system, because it's the opposite of the normal temperature rhythms of the human body, which calls for cooling off of the body in the evening to prepare for sleep and warming up of the body in the morning, to prepare for waking. You can tell that this is happening because those with a temperature regulation problem have a very difficult time waking up in the morning, and they want to stay in bed bundled up in blankets. Again, parents have a tendency to see this as difficult or oppositional behavior, the kid refusing to get out of bed. The truth is, because their body temperature is staying so low and not warming up, their brains are having a very significant difficulty waking. So it's not just a refusal, it's a biological need to stay asleep. Once you have become aware of what to look for in regards to temperature dysregulation, it becomes easier to intervene and manage that thermodysregulation. Now, next month, in our July webinar, our topic is cooling strategies and cooling plans. We will discuss in depth how to use specific body temperature regulation techniques, related items, and how to develop a schedule to integrate this temperature regulation into daily life. So if you're interested in learning about temperature regulation in a more practical and hands-on way, please join us in July for that. It's free and you can register for it on our website on the webinars page under the free resources tab. Now, I am going to give you a really brief overview of the strategies now. And the first, to the best of your ability, you're going to want to try to stay in a steady temperature environment throughout the day in the first place. Extreme temperature fluctuations in the environment confuse the body's already malfunctioning temperature regulation system. And so by avoiding extreme temperatures, you'll be able to reduce the stress on the thermoregulatory system. Some parents of kids who have FOH actually have in their plan that the children don't leave the house if the indoor temperatures and the outdoor temperatures are more than 25 or 30 degrees apart, because being able to stay in that steady temperature environment is extremely important. Next, don't make the person wear clothing that they don't absolutely have to. If they're willing to wear a sweatshirt but not a coat, let them self-determine that. This will assist in preventing some of that excess heat buildup that we talked about. The second way to manage temperature dysregulation is to help the body get rid of all of that excess heat that's trapped inside. This is something that's tricky to understand because a lot of people initially interpret this to mean make this person cold instead of hot. That is not what you want to do, because as I mentioned before, making the body cold turns on the body's furnace, but then it's not able to turn itself back off again when you need it to later, which causes the whole cycle of temperature dysregulation and overheating to just continue. Rather, the idea here is to make it easier for heat to just escape the body. And these strategies should ideally be done proactively throughout the day, whether you can observe overheating or not. That's what we call preventative cooling. And then sometimes when there's been a buildup of heat that you weren't able to prevent, you can use these strategies for what we call corrective cooling. The best way to prevent or correct overheating is to put the whole body into water. like a bath or a swimming pool, to pull excess heat out of the body's core. Water temperatures at a typical indoor swimming pool, like at your local YMCA, are about 78 to 82 degrees, which is the perfect temperature to help manage overheating. Taking a bath or going for a swim in this temperature range will provide a cooling effect by pulling heat out of the core without making the body feel cold. And this is the absolute best way of getting rid of heat and promoting mood stability with FOH. You can also promote heat release by reducing clothing and blankets that trap heat against the skin. Instead, you want to opt for really breathable fabrics or mesh that will allow for free airflow while keeping clear parts of the body that will overheat faster, such as the palms of the hands, the bottoms of the feet, the scalp, and the tips of the ears. I want to point out a lot of parents think that wearing Crocs, for example, will help because they have holes in them. Pro tip from parents of kids with FOH, Crocs don't have this effect because they're made of plastic. And so your feet actually sweat more in a Croc than if you're barefoot. So anytime the child or adult can be barefoot, that is absolutely preferable. You can also add fans to the environment to blow air across the skin, whisking heat away from the pores. You can also keep cooling cloths available, and these provide soothing coolness on the skin, which will actually prompt the brain to send blood to that area, and that allows more heat to leave the body. One of the absolute easiest and best for you in terms of your health cooling options is to drink a lot of ice water. This cools the body from the inside out and keeps the child hydrated. Now, one of the unique things about this diagnosis is that the temperature dysregulation doesn't just make people hot. This disruption, including the overheating, triggers symptoms that appear to be behavioral or psychiatric. But just as getting overheated can trigger behavioral and psychiatric symptoms, in the case of FOH, reducing body heat and stabilizing body temperature can assist in getting rid of those other psychiatric and behavioral symptoms as well. So let's look more closely at some of that and the things that are triggered by temperature dysregulation. The first thing that it triggers is an activation of the fight, flight, freeze response. The part of the brain that is supposed to control body temperature regulation is the same part of the brain that controls when the fight or flight or freeze response is triggered. This fight, flight, freeze response is the brain's sort of built-in response to danger, and it's designed to keep us safe. So when we encounter danger, our autonomic nervous system takes over and starts to make changes in the systems in our body in order to help us react appropriately to the danger. For example, in a fight, flight, freeze situation, our pupils dilate to take in more light so that we can see better. We start breathing harder and our heartbeat quickens to make sure that our muscles are getting all the oxygen that they need so that they can help us run faster and farther. And these aren't things that our bodies usually let us consciously control. Our brains take over and are preparing us to protect ourselves through either fighting, fleeing, or freezing. But with a dysregulated body temperature, the fight, flight, freeze response gets triggered when there isn't any danger and the fight, flight, freeze response isn't necessary. Now, I want to pause for a moment just to be really clear about this. This is not a case of an adult subjectively dismissing the fears, anxieties of a child. It has nothing to do with manipulation or gaslighting someone into not believing their perceptions. It is not about protecting an abuser or perpetrator of violence from the person who is trying to share their fears and concerns. It is not about PTSD in someone who has had and experienced an external trauma or ongoing traumatization. Those circumstances would be identified during a rigorous differential diagnosis process, which includes taking an extensive history. What we're talking about is a full-blown fight, flight, freeze response that is triggered by a body temperature disruption, not by a social or emotional trigger. A classic example of a fight, flight, freeze response becoming triggered because of temperature is one that's actually reported over and over and over again by parents and teachers, which is what happens when they ask the child to put their shoes on. So imagine it's morning, a family is getting ready to leave for school. They are frantically running about the house, making sure that the lunches have been packed and the backpacks have been packed and homework is in there and everyone has, what they need in their bags, and the parents are trying to get off to work and the kids are trying to get to school and you've got to feed the dog, and the parent asks their child to put their shoes on and he doesn't do it. And then a few minutes later, the parent asks again, and the child still doesn't do it. And after a few more frantic minutes, everyone's ready to leave, and the child still doesn't have his shoes on. And the parent, knowing that their child can be sensitive or misunderstand, takes a calm but stern tone and says, "Put on your shoes now, we have to leave." This in and of itself can be all that is required for the temperature disrupted brain to interpret "put on your shoes now" as a serious and dangerous threat. The response to this could be a fight with oppositional behavior, refusals, throwing things, hitting, screaming, and cursing. Now, if you're interested in hearing more specific and detailed description of a fight of this kind, I would highly recommend that you read an essay written by educator and advocate Liza Long, which she wrote in 2012, and it's entitled "I Am Adam Lanza's Mother." You can Google it and find it. She catalogs what these fights over things like, in her essay, it's whether or not her son is wearing blue pants or black pants. She catalogs what these fights were like with her child, who at the time that she wrote it was undiagnosed and had not received any effective treatment. Now, 11 years later, after getting a correct diagnosis and effective treatment, I'm happy to tell you that Liza's child no longer experiences these sorts of rages. And they shared actually a firsthand experience in their TEDx talk on what a transformation it was to get an accurate diagnosis and effective treatment. So if you Google Liza Long and "I Am Adam Lanza's Mother," you will find it. The second response to being asked to put your shoes on might be flight, which can include the child running from the room, curling up in a ball, hiding in a closet or under the bed, or crying uncontrollably. And lastly, a freeze response really just looks like no response at all. The child will likely give no indication that they've heard the instruction. They will go about doing whatever it was they had been doing before without any interruption. They may, however, stand still and be totally unmoving, or in some other way communicate that they are just not going to comply. To the outside eye, these behaviors appear irrational, confusing, extremely frustrating. And the parent is just thinking, we can't miss the school bus again. Why is he doing this? He just needs to put on his shoes. But on the inside, to the child, the response is a rational response to danger. To them, it's about their survival. And they genuinely do not realize that being asked to put on their shoes wasn't a threat. The same scenario plays out over and over and over again for these kids in different situations with different requests, from showering to homework to saying goodbye at a birthday party. On the outside, adults and caregivers see resistance and what they call misbehaving. But on the inside, the experience is one of extreme stress. And since untreated temperature dysregulation is always present, it becomes very difficult to escape that near constant state of stress, which in turn impacts behavior. So let's look at what that stress response is doing to these kids. The stages of stress include alarm, resistance, and exhaustion. When kids and teens are living with a mental illness like a mood disorder, bipolar disorder, or FOH, we see this stress response impact them nearly all day, every day. They're trying to cope under chronic extreme circumstances that nobody else is seeing or acknowledging. So when something happens, really anything happens in their environment, they feel threatened. This is especially the case with FOH's symptom of misperceiving threats. So what exactly is going on here? Well, the first thing that happens in the stress response is that they enter a state of alarm, which is essentially the fight, flight, freeze response we just discussed. Next, they enter the resistance stage, where the initial intensity of the fight, flight, freeze response has passed, but the body is still on high alert, hypervigilant, waiting for any other threats that might be on the heels of the first. If threats, and I want to stress this, even misperceived ones, are happening one right after the other and have overlapping recovery periods, then the body is staying on high alert all of the time and continues to produce stress hormones that keep this cycle going. Signs of an ongoing resistance stage are things such as irritability, low frustration tolerance, and low levels of concentration. The final stage of stress is exhaustion. In this stage, the avalanche of ongoing stress drains the individual of mental, physical, and emotional resources. They've essentially got nothing left in their tank. At this point, stress tolerance drops further, and they experience an inability to cope even with the smallest of setbacks. And levels of anxiety, fatigue, and depression all rise. Anyone who spent time around a child or a teen with mental illness will recognize all of these symptoms. But we tend, as outsiders, so to speak, to label all of these symptoms as behaviors, which implies choice and intention. Again, adults tend to view these symptoms as behaviors and see them as irrational and misperceive the child or teen as willful or intentionally disrespectful or even manipulative. However, from the inside, the person with temperature dysregulation is the victim of a biological process over which they have absolutely no control. And it's been triggered by a malfunctioning part of the brain that's also making their body not dissipate heat properly and making them feel hot when they shouldn't be. Kids, generally speaking, have little to no control on their daily lives and their daily schedules. So imagine for a second being a kid with a mental illness who's dealing with constant alarm, constant fight, flight, freeze, constant resistance, constant exhaustion. And when they can't stay on task in school, they're labeled as work avoidant, they're denied recess or given detention. But once we understand this stress cycle and how it is being impacted by a biological process, body temperature regulation, which the child has absolutely no control over, we can see how cruel these kinds of punishments actually are. Temperature dysregulation also significantly impacts the body's ability to regulate healthy sleep patterns. And people with bipolar and FOH experience a whole host of sleep disturbances, including trouble falling asleep, trouble waking in the morning, and extreme restlessness during the night. They have sleep inertia, and they also have disruptions in the transitions between REM and non-REM sleep, which are called parasomnias. REM sleep problems include nightmares and night terrors, sleepwalking and sleep talking, bedwetting and teeth grinding, and even hallucinations that occur on the cusps of sleep. So imagine being a small child and becoming conscious during REM sleep. The body is paralyzed during REM sleep, and they're experiencing very vivid, horrific nightmares, often themed with pursuit, abandonment, violence, blood, and gore. And yet you're conscious and unable to move. This combination of nightmare and sleep paralysis is plain and simple traumatizing. In fact, the repetitive nature of the nightmares is an ongoing trauma that contributes to the continuing cycle and stages of stress. It's hard for many people to imagine that the problems regulating body temperature could possibly produce all of these sleep disruptions and in turn cause, what are seen as behavioral problems. The decades of research in sleep have shown that there are changes in brain waves as a result of temperature changes in the body, and that produces these significant symptoms. Researchers at the Juvenile Bipolar Research Foundation conducted a study on this phenomenon at Cornell University's Sleep Center. And in this study, they looked at sleep-wake records measuring the body's surface or core surface and core temperatures. Remember, we talked about the difference between shell and surface temperature being an objective way of measuring and identifying temperature dysregulation. So these two temperatures, core temperature and surface temperature, or proximal and distal temperature, are supposed to align at the beginning of sleep and then again align in the morning in order to wake up. So you can see in this graph here at around 2300, which would be 11 p.m., the red line and the blue line intersect. And then they intersect again around 7:30 or 8 a.m. the next day. During the night, while they're sleeping, that distal temperature, that surface temperature is, for the most part, higher on the graph than the proximal or core temperature is. Now, the second graph shows the temperature cycles in FOH patients. The two temperatures don't ever line up. The red and blue lines do not ever intersect. So this data shows that this misalignment in the evening results in difficulty falling asleep. There's no intersection. The same misalignment in the morning disrupts the ability to wake up properly. And in the middle of the night, when surface temperature is supposed to be generally higher than core temperature. In the FOH patient, it's totally out of whack with core temperatures far above surface temperatures. This causes all of those parasomnias that I talked about earlier. Fundamentally, this temperature abnormality is the marker, and the reason why children, teens, and adults with temperature disruptions and FOH have significant sleep disruptions, both in getting to sleep and getting up in the morning. And they usually start from a very, very early age. Some parents can track these sleep disruptions to infancy. So as you can see, temperature dysregulation is a biological marker for FOH because it's a biological phenomenon. It can be measured, and it indicates the presence of the disorder and the severity of the disorder's other symptoms. In fact, temperature dysregulation has been such a key aspect of identifying and treating bipolar FOH that despite the fact that the name continues to evolve through research, something temperature related has almost always been included in the name. So as research continues, the name changes in response to the information and insight new data provides. And of course, the name won't be officially established until the DSM review committees determine one before it's added into that book. But currently, researchers are using thermoregulatory sleep dysregulation disorder as the name, while continuing to use FOH as a shorthand. Hopefully, by now, you'll agree that the biomarker of thermodysregulation is crucial in understanding and treating FOH. By understanding the effects that thermodysregulation has on behavior and sleep, we can understand the individuals who live with this condition with renewed compassion and empathy. And with the known biomarker, we can target treatment at its cause, and the behavioral and sleep symptoms can be addressed in a way that we've never seen before in mental health. Thank you for being with us. This slide has information on the works that were used in the development of this presentation. And lastly, if you would like a certificate of completion for the webinar, please email programs@cmhrc.org, and make sure you let us know if you are a practitioner, mental health provider, or if you are a family member or a patient. We do have different certificates depending upon that factor. So now we can dive into a Q&A for just a few minutes. Jen, I think there were some questions that you have for discussion. Two questions that I'm seeing here already from you are, does where you live, such as a hot city, impact the symptoms? Yes, it can. The thing about fear of harm and this temperature dysregulation is that, as I said, being in an unstable temperature environment has a really negative impact on the body's ability to gain control over its temperature regulation system. And so, for example, if you live in a place that's really hot, then you're probably going in and out of air conditioning a lot. And what's happening there is you are going from, say, 68, 70, 72 degrees indoors to, say, 95, 96, 98 degrees outdoors. That's potentially a 30-degree temperature swing, which makes the body very confused. The same is true in cold temperature locations, where going from the house to the car, to school, out of the car into school, out to recess, where all of those things are taking them from an indoor environment that is really sort of held in sort of a neutral zone, and making the body figure out back and forth what it's supposed to be doing with these wild temperature swings. So yes, where you live does matter. And we do find that folks who live in more temperate areas with steadier temperatures, less dramatic temperature swings from highs to low, less humidity, less fluctuations in barometric pressure, often have an easier time managing their symptoms. I see that there's another question here on how come the symptoms of FOH overlap with ASD and ADHD. One psychiatrist says FOH symptoms may be better explained by ASD and ADHD. That's a great question, and actually one that we get a lot. Just put it that way. So the diagnostic criteria for fear of harm includes 7 different symptoms. Unlike other diagnoses that are in the DSM, like ASD, like ADHD, those diagnoses will give you a list of symptoms, maybe 6, 8, 10 symptoms. And then you have to pick which ones you have. And if you have only you only need a certain number of them. You know, with major depression, you need 5 out of 9. That's not the case with FOH. You actually have to have every single symptom present in order to be diagnosed with the disorder. And the first symptom criteria on that list is a diagnosis of bipolar disorder. So automatically, that is a way that we differentiate FOH from ASD. Kids with ASD are not going to also routinely have a diagnosis of bipolar disorder. Sometimes they do, but that is not routine and that is not super common. And so what we are experiencing here is, yes, there are some overlapping symptoms, but when you look at the FOH diagnostic criteria and you see that every single one of them, including temperature dysregulation, has to be ticked off, then you know that if they're missing that bipolar diagnosis, if they're missing the temperature dysregulation, if they're missing the sleep disruptions, then it's not FOH, it's something else. And so if someone has all of them, then we really want to look and re-examine and not just fall back on the diagnoses like ASD and ADHD that most practitioners are familiar with. And that's hard, getting people to move out of their comfort zone of what they've been trained in. So it's not uncommon, but one of the services that we provide is that we have a community mental health advocacy program where we work with families to attempt to communicate with their provider to understand all of the diagnostic criteria, to understand the research behind it, and to help get clarity around what diagnosis is likely correct. We certainly don't see FOH in everyone because it has to match up every single criteria. There's a question here about how does this impact adults who were not diagnosed as children? How does this present in adults? It actually presents very similarly. On a biological level, it's the same. The difference is adults tend to have a lot more control over their environment and their daily life. And so adults are able to make accommodations for themselves that children can't. So for example, a person with temperature dysregulation may wind up working from home so that they don't have to go in and out of various temperature differentials throughout the day, leaving, going to work, going to lunch, leaving, riding the subway, taking a train, getting in and out of a hot car. They may simply be able to eliminate all of those factors for themselves through the work that they choose. But fundamentally, on a biological level, the same thing is happening for an adult who has a temperature dysregulation issue than a child. Someone is asking specifically about cortisol changes and temperature regulation. Can you please email us that question, and we will get you resources and send them to you. That would probably be the easiest way to answer that question. I see that we have hit the end time for the presentation. If folks have additional questions and want to stick around, we can do so for a little while. Otherwise, I want to respect people's time and show our appreciation for you being here by letting you out on time. Again, if you would like to have a certificate of completion, please email programs@cmhrc.org. Members of CMHRC have access to a full archive of all of our webinars, and professional members additionally have access to an archive of all of our clinical seminars. It's very inexpensive, less than Netflix, for members to be able to have access to that, plus other services. So if you are interested, you can check that out on our website, on our memberships page. We are a nonprofit. All of the work that we do is paid for through charitable giving. So while we don't charge for these webinars, if you attend them regularly, if you find the information in them valuable, much like a museum, we appreciate a donation in exchange for the service that we're providing. And you can do that on cmhrc.org/donate. You can sign up for upcoming webinars on our website at cmhrc.org/webinars. So to those of you who are going to be signing off now, thank you for being here. I see an additional question. How can we reach you if we want to consult with you about our own needs? That's a great question. We have a number of programs and services that we have to support families and providers. So what we do is we have a diagnostic consultation service where a team of mental health providers review everything that has ever been written in any report or pediatric records about you or your child. And we cull through that. We do our own assessments. We do our own interviews with you in order to figure out what is the most likely correct diagnosis. It may be one you've already been given. It may be one that you have not. We collaborate with your providers on ensuring that they understand the research behind the diagnoses and what the best practices are in terms of treatment. We also have our community mental health advocacy program that I mentioned just a moment ago. And we also have a school advocacy program where we work with families to ensure that your child who has a mental health issue like a mood disorder or bipolar disorder, or if they have fear of harm, also their biological thermoregulatory condition. We work to make sure that that child is getting the accommodations and modifications that they need at school in order to be successful in that environment. We also have, as I mentioned, our membership program. We have a online web app called the CMHRC Toolkit that helps parents and individuals with mood disorders, bipolar, or FOH track their symptoms, their moods, their medications, and graph the results and get a sense of what is influencing their mood, how their symptoms are improving or not, and what effect the medications that they're taking are having. So you can also find that information about that on our website, cmhrc.org/toolkit. Transcripts are not available. As I said, members have access to our full archive, which means that any CMHRC member can go in and view every webinar that we offer. New ones are added. This one will be added over the next week or two. And our clinical seminars for professionals are also added after they happen. If you are a professional, we're having a clinical seminar next week that is a deep dive into fear of harm, how it was first identified, why it's called what it is, what its symptoms are, how you diagnose it, and how it's treated. So clinical professionals are invited to register for that free event as well. And within a few weeks of its happening, we will make it available on our website for our members. There's a question here about how to diagnose a child who's between 8 and 10 who isn't diagnosed with bipolar but has all of these symptoms. That is a question that we couldn't possibly answer without much, much more information. And so what I would say is, if this is a concern that you have, contact us. Email programs@cmhrc.org. Let them know that you're interested in getting more information about our diagnostic consultation program. You can also look that up on our website, cmhrc.org, under services, and we can work with you on getting those answers for you. It may be FOH, it may not. We're more interested in making sure that you get the correct answer than anything else. So, Jen, are there additional questions?
Not that I can see at this time. Let me go back. We got the cortisol. We answered these symptoms, are they impacted where you live? And then we covered the ADHD and autism. So I think we have everything at this time.
Wonderful. So thank you for being here. Again, if you have additional questions or want to talk to us, you can email programs. You can also email admin@cmhrc. You can make a donation on our website if you're so inclined, and you can reach out to us about any of our services at any time. Remember, no one has to face this alone, and we are here to help. So thank you so much for being here. Bye.